of this drug, Mefloquine, also known as Larian. I've been invited to update you on this research and the current state of knowledge in the field. What follows is a very fast-paced 15-minute presentation. Mefloquine belongs to a class of compounds known as quinolines. Despite the known neurotoxic and neuropsychiatric effects of related quinoline compounds, when mefloquine was discovered about 40 years ago, it was initially thought to be free of most of these effects. It was only after U.S. licensure, a little over 20 years ago, that a familiar pattern of serious side effects were revealed. These included disturbing reports of psychosis, dissociation, and even suicidal ideation associated with use both in therapy and in prophylaxis. The current product insert warns of a risk of encephalopathy and a range of psychotic and dissociative symptoms, as well as alluding to a potential risk of suicide. Despite over a decade of licensed use and at least a decade of earlier use as an investigational new drug, it was only in 2002 that the Department of Defense issued the first formal guidance for the safe use of the medication, prohibiting it among soldiers with a history of mental illness. Soon after this, the Veterans Administration investigated concerns of possible long-term effects associated with the drug, including a syndrome resembling PTSD. The VA has recently acknowledged a growing literature linking mefloquine to suicide and acts of violence. And the VA has recently engaged in additional literature review and patient outreach to identify and study potentially affected veterans. This year's CDC Yellow Book concedes that mefloquine use may confound the diagnosis of post-traumatic stress disorder and traumatic brain injury. And in September of 2009, and this depends on how you interpret the word should, DoD formally prohibited the use of mefloquine as first-line chemoprophylaxis. AFRICOM and CENTCOM have subsequently issued similar policies. Now, the reasoning underlying these policy changes is not well described, but seems to be related to mefloquine's unusual and yet still poorly understood side effect profile. In the remainder of this presentation, I hope to update you on current knowledge and leading theories in this area. It is often erroneously claimed that mefloquine is safe to use among those who have previously tolerated the drug, or safe to use among those who have no personal history of mental illness. However, a critical reading of the literature demonstrates that adverse effects routinely occur even among those without apparent risk factors. Why is this? Understanding why requires an appreciation of the drug's complex pharmacokinetics. Mefloquine is highly lipid soluble, and as a result, significantly less than 1% of the drug contained in each tablet is ultimately found at the site of its anti-malarial activity in serum. What remains of the drug is tissue-bound. As a result, the drug displays highly erratic and unpredictable serum pharmacokinetics across populations, reaching levels as high as 6 micromolar and frequently remaining subtherapeutic, as low as 1 micromolar, as this graph demonstrates. The lipophilicity of the drug means that it tends to quickly cross the blood-brain barrier and accumulate in brain tissue, where under ordinary circumstances it is rapidly effluxed by membrane transporters, most plausibly the ATP-dependent P-glycoprotein transporter, or PGP. PGP is subject to transcriptional regulation, is genetically heterogeneous, and is subject to significant competition and inhibition by common compounds. Variation in brain accumulation of mefloquine in the presence of such pharmaceutical inhibitors was recently confirmed experimentally. The inhibitor alacridar resulted in an immediate doubling of mefloquine brain concentrations. These increases in concentration remained at 1 week after dosing in the presence of the inhibitor. There are numerous PGP inhibitors and substrate competitors in common use, including common psychotropic medications, antibiotics, and opioids, only a small number of which are listed here. The genetic basis of PGP variability finds homology in the malaria parasite itself. where mutations in the gene coding for the plasmodium equivalent of this transporter, PGH1, which increase copy number or which more efficiently pump mefloquine out of the parasite's food vacuole, will be evolutionarily adaptive and will be selected for under drug pressure. This is the origin of mefloquine resistance. So it seems straightforward to conclude that polymorphisms in the gene coding for human PGP, which result in the opposite effect, either a decreased copy number or reduced function, would result in an equivalent increase in human brain parenchymal concentrations, and thus contribute to a risk of dose-dependent adverse effects. And indeed, at least among women, this was found to be true in a recent study, with up to 10-fold increased risk with certain polymorphisms in the MDR1 gene coding for PGP. So, with the epidemiology at least partly explained, what is the pathophysiology or mechanism of these effects? Insight into this question has come only recently with the demonstration that at relevant concentrations, mefloquine potently disrupts certain vital neuronal signaling processes. In 2004, mefloquine was found to be a potent blocker of intercellular communication through what are known as gap junction channels, formed by proteins called connexins. Gap junctions form electrical synapses linking neurons directly through channels that can transport ions and small molecules. They are critically involved in neuronal synchronicity throughout the limbic system, regulating the functions that underlie learning, memory, and the coordinated responses to stimuli. At doses consistent with plausible brain accumulation, mefloquine disrupts and even eliminates such coupling. At similar concentrations, mefloquine disrupts subcortical interneuron regulation. At these concentrations, mefloquine also directly affects electrical activity in the amygdala, the portion of the limbic system critically involved in processing emotion and fear. Within the amygdala, the drug acts in direct opposition to the effects of anxiolytics. This may explain in part the drug's anxiogenic properties. Mefloquine may also affect coupling in the brain centers controlling sleep-wake control. In this study, mefloquine counteracted the effects of modafinil. Mefloquine directly affects fear conditioning within the hippocampus. The drug modifies context fear response. So, the evidence is clear that at doses consistent with chemoprophylactic use, mefloquine may exert profound and behaviorally relevant effects on critical neuronal processes within the limbic system. Now, these experimental findings still lack validated human clinical correlation, but attempts at developing an integrative theory are now possible. A theory of mefloquine adverse effects should include, at a minimum, an explanation for the drug's preferential target effects within the limbic system, explain the drug's characteristic prodrome, its contraindications and epidemiological risk factors, and be sufficient to explain both the acute and chronic effects of the drug. And ideally, such a theory would help to inform diagnosis and treatment of those affected by such adverse effects. I propose a syndrome of mefloquine limbic encephalopathy. Mefloquine produces a clinical condition closely resembling a related limbic disorder known as anti-NMDA receptor encephalitis. It too, like mefloquine encephalopathy, is preceded by a variable prodrome of sleep disturbance, vivid dreams, and mood changes. The prodrome of mefloquine encephalopathy may represent the effects of rising brain concentrations of the drug. In most users, resultant upregulation of PGP will result in the rapid efflux of the drug after dosing and contribute to the development of a tolerance. However, in a subset of users, genetic polymorphisms or drug or possible environmental causes of PGP inhibition will lead to rising brain levels and dysregulation of limbic dopaminergic and noradrenergic transmission, resulting ultimately in a dissociative psychosis. The limbic target effects of the drug may explain its epidemiological association with acts of violence. Mefloquine is the only non-psychotropic drug listed among the top 10 most associated drugs in a recent analysis. The literature also contains numerous case reports of stunning acts of violence associated with the use of mefloquine. Most recently, a case report describes a particularly violent suicide by repeated skull stab wounds. This case suggests evidence of persecutory delusions, hallucinations, and dissociation. The carving of a cross is suggestive of the religious themes noted in many earlier reports of mefloquine psychosis, and the repeated skull stab wounds suggest a strong dissociation from fear and pain stimuli. The dissociation seen in limbic encephalitis and in mefloquine limbic encephalopathy resembles to some degree the glutamatergic dysfunction induced by the dissociative anesthetic agents, particularly phencyclidine or PCP, but also resembling to some degree what is seen in ketamine. Adverse reactions to these drugs, as you know, are well characterized and frequently marked by absence of fear of consequences and amnesia to the event. Now we need to break quickly, and in the last few remaining minutes turn to chronic effects. Mefloquine has been demonstrated to produce a highly dose-dependent, permanent neurotoxicity in the brainstem of animal models. This is remarkably similar to the highly specific pattern of brainstem lesions caused by experimental quinolines developed by the U.S. Army in the 1940s and 1950s. These lesions occurred in highly variable areas of the brainstem, depending on the animal model studied, but were also found in at least one human examined at autopsy. These lesions were too small to be seen on MRI today. Interestingly, in these studies, many affected animals exhibited significant disequilibrium, suggesting involvement of the vestibular nuclei. And indeed, vertigo and disequilibrium have long been recognized as significant side effects of mefloquine, although permanent effects have generally been considered unlikely. Yet in 2004, the Navy identified a cluster of patients reporting chronic symptoms of vertigo associated with mefloquine use. In many, psychiatric symptoms were more prominent, and vestibular effects were subclinical and identified only on careful testing. In patients with such central vestibulopathy, clinical testing may be challenging. Findings may inconsistently mimic peripheral lesions or may even appear aphysiologic. This may be particularly true on automated testing, such as computerized dynamic posturography. Yet there is growing evidence from case reports that a consistent pattern on computerized dynamic posturography may be sufficient to detect the unique permanent fingerprint of mefloquine-induced brainstem lesions. Further testing of this hypothesis on appropriate patients is urgently needed. In addition to this Navy vestibulopathy cluster, there is growing anecdotal evidence that many patients experience long-term effects from this drug. Plausible mechanisms of long-term injury include not only delayed efflux from long tissue half-life, but indirect permanent effects such as limbic seizure disorder, or even simple conditioning, such as what is seen with PTSD. Direct neurotoxicity and apoptosis are also likely causes. It is important to emphasize that there have been no formal studies of long-term effects, and thus these long-term effects cannot be excluded. When these important studies are finally performed, it will be important to determine whether chronic effects are associated only with fulminant encephalopathy, or whether the presence of even mild prodromal symptoms during dosing are sufficient to create a risk of long-term harm. Now, mefloquine has been widely used within DoD and within the special operations community, beginning as an investigational new drug during the 1980s and possibly even late 1970s, and continuing through the present day. Over 160,000 electronically documented prescriptions are recorded, but the true number is likely significantly higher. The drug has been widely prescribed off-label to those with contraindications. During a recent deployment to Afghanistan, 1 in 7 with documented contraindications to the drug were nonetheless prescribed mefloquine. Contraindications to the drug are, in general, poorly understood by most users. It is incorrect that only those with contraindications are susceptible to adverse effects, but it is likely that those with contraindications are at some increased risk. Among those with pre-existing mental health disorders, symptoms of mental illness may result in users of mefloquine attributing prodromal symptoms to their pre-existing diagnosis rather than to the drug. making it less likely that they discontinue the drug at the onset of encephalopathy. Similarly, simultaneous use of psychotropics may not only compete with mefloquine for PGP efflux, but may mask symptoms of a developing mefloquine encephalopathy or make recognition of this prodrome difficult. And it is important to emphasize that episodes of psychosis and long-term adverse effects have been reported after only a single 250 milligram tablet. Those suffering adverse effects from mefloquine may have a highly variable chronic presentation, which, as noted by the CDC, is confounded by many prevalent conditions on the battlefield, such as TBI. Patients may present with personality change or with a syndrome resembling PTSD. They may exhibit chronic memory impairment, particularly in working memory, or sleep disturbances. And of course, vestibular or equilibrium deficits are common. In my experience, a common feature is a diagnosis of ill-defined condition and suspicion for a somatoform disorder. The diagnosis of mefloquine toxicity should be considered in any such patient who has confirmed exposure to the drug and some evidence of earlier acute effects, particularly memory loss. There's currently only a single clinical or epidemiological research project underway within DoD to further explore some of these theories. I expect results of this one study in mid-2012. This study will examine the association of genetic polymorphisms with acts of suicide and various mental health outcomes. While we wait for additional clinical studies, service members endorsing persistent mood or behavioral changes, sleep disturbances, disequilibrium, or vertigo following exposure to mefloquine may benefit from further testing, including consultation with ear, nose, and throat specialists for clinical evaluation and central vestibular testing, including computerized dynamic posturography. Providers are encouraged to contact one of these two informal referral centers for further information. I am over time, so that concludes my talk. Thank you for your attention. I'm happy to take a few brief questions or respond to comments. Thank you.